So, hi, hello everyone. Thank you, Jordan, for the invitation. Can everyone see my screen? Is it
Yes, we can.
and can you hear me well as well?
Sounds excellent as always.
Okay, perfect. So, thank you, Jordan. Thank you everyone for attending, and Jordan for the invitation. So, just a brief introduction. My name is Marcelo. I'm a pediatric radiologist here in Brazil, São Paulo, and I spent half of my time in clinical practice and the other half working with AI in radiology and mostly either in in-house development of AI algorithms or also in actually deploying these algorithms into clinical practice. So, and I'm going to talk a little bit about AI in pediatric imaging. So, okay, so I've summarized here what I wanted to talk about. Briefly discuss the current state of AI in pediatric radiology, and then I'd like to talk a little bit about what I think are the meaningful uses of AI AI in pediatric radiology, both in short-term and medium-term perspectives, and some final words. So first, a little glance at what the state of AI is in pediatric radiology currently. This is a a graph of a PubMed search I did a couple of days ago, and with the two keywords, radiology and artificial intelligence. And so these are the results by year. This isn't the most accurate search, but it's just an easy way of showing comparing. So for just radiology, I got 16,000 results, over 16,000 results, mostly after 2015. And when I did the search for pediatric radiology, you can see that the number it falls down quite a lot, and for a total of 320 results. So, and again, mostly after maybe 2018, most of the publications. So even though this isn't the most accurate way of getting exactly how much is being published, it's just to show that it's quite different. So if we think about pediatric radiology and artificial intelligence, it represents maybe 320 out of 16,000, 2% maybe. So it's a very small fraction of what is being published in actual radiology and AI. And so this kind of shows that pediatric radiology has lagged in comparison to other radiology subspecialties regarding the use of AI. And I'll just briefly discuss why I think this is happening. So these are the reasons I think are most responsible. First, children do less exams than adults. They actually tend to need less exams, and they're uh, uh, they are healthier. There are very few exams that need to be done in healthy children. So we have less exams in children. Also, the population is heterogeneous, meaning that at least here in Brazil, when we talk about pediatric radiology, we talk about radiology that assists children from 0 to 18 years of age. And so you can imagine that even the normal exams can be very different from a preterm, maybe a brain MR or uh, a bone plain film, like a MSK plain film. It is very different if you pick a preterm or a neonate or a toddler or a teenager. So this kind of makes things a little bit harder to generalize in all of pediatric population. So then this is another point. Also, children have different diseases. And even if you think about the same disease, so for example, a pneumonia or a stroke, the physiopathology of the disease will probably be different, and the not only this, but the actual radiologic finding might be different. So it's kind of hard to you can't expect to translate that an AI algorithm that was developed for adults and trained and validated for adults. even if you're talking about the same disease, it probably will not perform as well as it does in adults with children. So you would have to uh, tune this algorithm or even retrain it for children. And also, children have pediatric radiology has a different approach to many diseases from adults. So at least here in Brazil, we tend to use a lot more ultrasound and plain films and X-rays than CTs and MRs. And this isn't the same in adults. So if you have um, a suspected here in Brazil, at least, if you have a suspect of a child with an abdominal pain, we try to solve this as much as we can from the ultrasound and try not to go into other modalities. So things are a little bit different. So it's not that it's harder to develop AI in pediatric radiology. It's just that it's different from the adults, and we can't always extrapolate these models or these algorithms that are developed for adults directly into the pediatric population and expect the same results. But this isn't to say that AI isn't. There aren't any well-known uses of AI in pediatric radiology. Actually, so bone age for the evaluation of skeletal maturation. This is the most well-established AI application in pediatric radiology, and I believe it's very it's in a very mature state. This, I believe, is a low-hanging fruit kind of problem for AI in radiology because bone age assessment consists of a repetitive classification problem, and you only have one image that you have to classify. So just, I'm sure you are all aware of this, but just to illustrate, so when we're talking about bone age evaluation, we usually have uh, a plain film of the hand and the wrist and of the left hand and left wrist, and then you just compare this to the most used method is comparing it to an atlas. So you go into the atlas and you search for specific landmarks, and if they are present, then you can classify this as the specific age. So this is a very nice test to apply AI in radiology. And computer-assisted bone age assessment is not something new. It has been described, I believe that one of the first authors to describe the use of assistance in bone age assessment. It was published in 94. And in 2009, so Feldberg and colleagues, they published this paper on the bone expert method. This actually became a commercially available software, and this was back in 2009, so over more than 10 years, over 12, 13 years ago. And interestingly, the software it is available. It is readily available, and it has been used in mostly in Europe. I guess here in Brazil we don't use it that much. I don't know if in the US you have many centers using it, but I know that in Europe there are a lot of centers that use this actual software, which is basically an AI evaluation of bone age. And interestingly, this group just published in the beginning of this year, so January 2022, a I'm sorry, a an article about a survey they sent to people who were using Bone Expert, and this is a very nice article. I really recommend reading this because it has some interesting insights, and I think that the most interesting part of the article, for me at least, it's this table here. So basically, we have here the percentage of respondents on the y-axis, and on the x-axis you have the time that they take to evaluate bone age. And the black bars are before they implemented, they started using Bone Expert, and the white bars are after. So let's start from right to left here. On this, this here is over 5 minutes. So before Bone Expert, on the survey, 37 respondents said that it took more than 5 minutes, And after the use of Bone Expert, this dropped dramatically to just 1. And I'm sorry. So in the 2 to 5 minutes bracket, so before Bone Expert, 49 respondents took between 2 and 5 minutes, and after this also lowered to just 20, and so less than 2 minutes. So this is where there was the largest change after Bone Expert. So there were only 9 respondents that used to spend less than 2 minutes reading bone age images studies, and this jumped to 62 respondents. So this was quite a big change. But for me, the most interesting part is this one. So no time, meaning that no radiologist actually assesses the images, the studies. So I'm not sure how this works in Europe. Maybe here they just they did the images and they did not report and they left the actual interpretation for the referring physician. But the interesting part here is that before they had actually 5 respondents that did not spend time reading these exams, but after there were 17 respondents who stopped, or 12 more that stopped actually looking at the images. So it's kind of scary because it shows a software actually doing the radiologist works to the point that the radiologist does not need to actually um, look at the image. But it's also interesting because even though the software is rated for actually a complete automate evaluation of bone age, still many places, many respondents still prefer to actually look at the images rather than simply leave it all to the software. So this is something interesting. And now I'd like to talk a little bit about what I think are the meaningful applications of AI on short term. So for pediatric radiology, the first thing, and this is the what I think is the most what will come, what will be the fastest thing to happen is providing better and safer exams for children. So in pediatric radiology, we have many concerns on which method to use, specifically for MRI and CTs and fluoros. So for MRIs, the exam length is a problem for children because they're related not only to the need and the time of sedation, but also to motion artifacts. So if the exam takes long, patients will probably will have a higher likelihood of moving during the exams. And also longer exams also mean that probably the patient might not tolerate and might need sedation. And obviously, the longer the exam, and if the patient is sedated, the longer the sedation. And for MRI, also gadolinium contrast medium, the long-term effects in children, it's still discussed, and we try to use the least amount that we can for contrast and MR for children because of deposition. So tissue deposition of gadolinium. So this is another concern. And for CT and fluoro, I think that the main concern is radiation exposure, which is related to, so the lower you go with the dose, the noisier the image gets. And so AI can be used and to shorten the length of the MR exam. And there are a couple of techniques like denoising, super resolution. These are names for them. There are many other techniques that can be used. And so the idea here behind this is that you could perform an MR exam with a normal scan length, like time. It would take the normal time, and you would have a normal image quality. But you can shorten this, and you don't use AI to actually shorten the. You actually can use AI to shorten the time, but in a more broader way, you actually either shorten the scan time and you increase the noise, you make the image noisier, or you can shorten the scan time and make the image in a lower resolution. And then you apply AI to these images, which were acquired faster, but in a lower quality, and you bring them back to the normal quality. So this is already available. Not necessarily this specific, like denoising or super resolution. There are some other more complex ways of doing this, but most MR vendors are already doing this in their own MR equipment. So when you buy a new equipment, you can actually buy it with this specific softwares. And there are also third-party companies which also commercialize this kind of software. So you don't have to actually buy a new MR. You can just look for a third-party company which does this kind of inference. So you just manually adjust the settings of the MR so you can make a faster scan, and then you send it to the algorithm, and it will return to you a higher quality image after it's processed. The same thing goes for reducing ionizing radiation dose on CTs or fluoros. So this is an interesting systematic review, a recent from July of this year, in which basically with CTs and fluoros, when you reduce the dose, you end up getting a noisier exam. So it's more or less the same as the denoising for the MR. And on the systematic review, what the author shows is that many studies are showing that you can reduce the radiation dose between 35 and 70% without losing diagnostic information, as long as you pass this noisy image through a denoising algorithm. This is another interesting paper on actually reducing the dose of gadolinium in contrast brain MRs. So basically what they did on this paper is they did the gadolinium injection in 2 separate times. So the first time they inject only 10% of the dose, and they do an acquisition of what would be a low dose MR. And then they inject the remaining 90% of the dose, and they get a full dose acquisition. And so they've built an algorithm that can translate these, can actually predict what the full dose of the image would be based on the low dose image. This way you can reduce the dose of gadolinium. And this is also very interesting for children because of the concerns of tissue deposition of this kind of contrast. And as for medium-term perspective, there are 2 things that I would like to touch. First one is questioning the current state of radiology. So this is a very interesting article. I think it's 2020 or 2021. I'm not quite sure. But basically, what the authors did here, they actually, so when we're doing bone age assessment, one of the most classical way of doing it is using the Graylich-Pyle atlas, which is a node atlas which was elaborated on a very specific population in the US. And what these authors did here, they actually tried to base the bone age assessment not on this atlas, but on what would be a specific data for specific populations that was being analyzed. So they actually retrieved studies for hand x-rays for trauma for kids in a specific region in the US, and they assumed that all these kids would not have any growth disturbance, or if they had the growth disturbance, it would be diluted in the middle of many normal exams. And they actually used the population itself as the benchmark for evaluating bone age. So they actually managed to make something specific for that population, which is very interesting. And the other thing that I would like to touch on is integration with clinical data. So I know that in the US, this is much more easier than here in Brazil. Here in Brazil, we still have a lot of trouble integrating images and clinical data into large data sets. And this is a very interesting paper in which basically they built a data set of over 4,000 cases of patients who were hospitalized with clinically defined severe and very severe pneumonia. And one of the findings is that normal chest x-ray cases were common in these patients who were hospitalized with severe and very severe pneumonia. So you can imagine that if you're going to train an algorithm to detect pneumonia and you're going to use the report as your label, then in this case, you would actually be labeling x-rays normal, in which the patient actually had clinical clinically defined severe and very severe pneumonia. So this is something that I find that would be very interesting as well, because we might be able to go beyond what we as radiologists can see, and use AI to improve even further. But this might take a little while, because collecting this kind of data is not that easy. So hello, can you guys hear me?
Oh yeah, we lost you for a
Okay.
second, but you're all good.
Okay, sorry. So to summarize, AI development for pediatric radiology has been slower than in other radiology areas, and this I think is this is something that happens in pediatric radiology. We tend to always lag behind these kinds of new developments. But there are cases of where AI is really useful. Bone age assessment is a very good example of that. And I think that this is just my opinion, but the use of AI in tasks that other than detection and diagnosis will probably have a much higher impact in pediatric radiology workflow, at least in short, medium term. Oh, thank you very much.
That's excellent. Thank you so much, Dr. Strauss. I have a question here in the Q&A that I would also be very interested in your thoughts. You mentioned bone age as a kind of low-hanging fruit, as a good opportunity to integrate AI. Are there other areas in pediatric imaging that you consider low-hanging fruit?
So that's a good question. For me, I'm very fond of quantification, and I find that here in Brazil, at least, pediatricians, they tend to value the measurements that we make. So when we do a ultrasound, or when we maybe a kidney and bladder ultrasound, or liver ultrasound, they're often very interested in the size of things, of how we measure them, and this is something that we do normally, but then the question comes: is this normal, and is the size normal? And we don't have that many studies, at least here in Brazil. I know that there are worldwide a couple of studies, but they're very specific for each population. So it's hard to translate these measurements into what is this actually normal for the Brazilian population, or whatever you are. And I think that this is something that I find interesting, that we can. There are many algorithms right now on actually measurements of body composition and organs, and if we can use this, let's say if I can get, I don't know, maybe 1,000 CTs or 2,000 CTs from patients that I know that do not have a specific pathology on that organ, and actually use an AI algorithm to measure them and actually plot what the normative values would be for those. That is something that I think that might add value, and it's something that we already have, or I don't know if we already have them well established, but there are lots of papers on this for adults. So maybe that would be establishing, using AI to establish, like summarizing, using AI to actually establish normative values for measurements in pediatric radiology. That's something that I think that might be feasible soon. Jordan, I think you're on mute.
Forgot to unmute myself. I've used Zoom before. But yeah, I think that's a great point, touching also on some algorithm bias and some of the applicability, generalizability that we talk about with some of these AI tools. Specifically related to bone age, like you were talking about, that even our gold standard, or the gold standard a lot of us use here in the United States, the rule of compile, has been shown to have some inherent bias, that it doesn't apply well to populations outside the United States, and consistently underestimates for patients of African descent. There was a large study out of South Africa, I think in 2018, that sticks out in my mind. But yeah, that's an excellent perspective. Do you have any additional closing thoughts?
No. Just like to thank you. Thank everyone for being here and spending the time. Thank you all very much.